In order to accomplish the goals just presented, the Perinatal Palliative Care Coordinator has tasks that are commonly required. The tasks are presented in Module 4. The learner at the end of this module should be able to list the task of the Perinatal Palliative Care Coordinator, describe how priority tasks will be determined, state 2 benefits of guiding parents through birth planning, and list the major areas of a birth plan. There are 5 primary tasks for the Perinatal Palliative Care Coordinator to complete in order to provide best care to the parents and the baby. Additional tasks could certainly arise as other parent or healthcare priorities are identified. Each task will be addressed individually. Assessing parent needs is done through listening to their story about themselves, this pregnancy, and their baby. When asked specifically about what they need or what their greatest fear is, what they value and what guides their decisions will come to light. Ask for clarification from each parent and family member of what you heard when needed. There may be a lot of variability in what parents need. Common areas of concern include baby pain and suffering, what is wrong with the baby, and why it is life-limiting, and the desire to have the baby born alive. Work to ensure the mutual understanding of others' perspectives. Often what is not said is quite important. Avoiding topics could be due to fear, a focus on other things, or lack of experience. Experience working with families will make this easier for you to recognize. Because pregnancy is a developmental process and parents' understanding and processing of information evolves, it is likely that parental needs will change over time. That is to be expected in subsequent meetings, so look for those changes. Task 2 is to identify priority tasks, requiring the care coordinator to assess how much time there likely is before baby's birth or death. This is based on gestational age or maternal health, or sometimes on a mother's choice of early induction. Parent priorities must be weighed in with hospital priorities. Competing priorities need to be reconciled whenever possible. Once the order of priorities is determined, the care coordinator guides the parents and informs that interdisciplinary team. There are times when birth is imminent or when parents have chosen not to make any decisions. In these cases, best care is provided using professional standards, with choices offered along the way when possible. Task 3, educate the parents, is dependent on the mother's past pregnancy and birth experiences, as well as the identified knowledge deficits of the parents. What is it that these parents need to understand about their current experience and prepare for upcoming events? Explanation should be accompanied by diagrams, photographs, or pamphlets. Group childbirth classes are likely inappropriate for palliative care families, so private instruction can be given or arranged. It is helpful to offer tours of relevant hospital units, such as labor and delivery and neonatal intensive care. Some parents may be interested in organ, tissue, or breast milk donations. Information on these options should be conveyed or meetings with key individuals arranged. Funeral options, including autopsy, can be provided by way of prepared providers or materials. Then questions can be answered as they arise. The task 4, develop birth plan, serves multiple purposes. A need for a completed plan in hand is the least important of all. The process of talking through the many topics in a birth plan, both between the parents and with the care coordinator, is the highest purpose. It requires clarification of parent values, priorities, choices, hopes, and dreams. These issues are described very well on the perinatalhospice.org birth planning pages. While parents agree that it is a most difficult conversation, they often agree that the topic list guides them towards much-needed thinking and decision-making. A written birth plan for delivery mode, timing, fetal monitoring choice, as well as newborn care immediately after birth and beyond are important for all hospital caregivers to know. Memory-making wishes can also be spelled out for all. The birth plan may be formally written or just understood or documented in provider notes. Consideration of maternal condition, fetal gestational age, and potential neonatal condition and interventions must be taken as well. The fifth task of disseminating the birth plan belongs to the Perinatal Palliative Care Coordinator. The current version of the plan needs to be shared with the parents and the entire interdisciplinary team. The location of the plan should be known by all and it may be in the electronic medical record or as a hard copy in a specified notebook on labor and delivery. Each hospital likely has different methods. The care coordinator should know how each area of the hospital wants to be notified. The parents should have a hard copy as well that they can carry with them. As a way to review the task presented in Module 4, consider this. Consider how the Perinatal Palliative Care Coordinator tasks may change over time with a family. How might the tasks of pregnancy with a lethal fetal condition guide your thinking? Work through the birth planning case provided in the link.